Okay, so I'm gonna do these two lectures back to back, and hopefully I'll be done by about 5 o'clock. New section, coagulation, new topic, and hopefully you'll keep up with me, but the other lectures are going to be relatively shorter, so I'm gonna be repeating this information later on, so don't be too alarmed if the information is too technical. And different. It's different than hematology. This is coagulation now. All right. So starting off, introduction to coagulation testing, the tests that are involved in coagulation testing. Routine coagulation tests includes the PT, the prothrombin time, the APTT, the activated partial thromboplastin time, fibrinogen, D-dimer. Those are the four main ones. And there are two other ones, the plasma protein paracoagulation test and the thrombin time. But the first four are actually the more common ones. The last two are the least common, but they are still orderable by the providers. The prothrombin time. Okay, so you're gonna see Roman numerals. Well, my philosophy is we're not in Rome, so we're not gonna emphasize too much on Roman numerals. So I'll translate the factors into numbers that you can recognize. The PT or the prothrombin time is useful in screening deficiencies in factors 2, 5, 7, and 10. Okay, measures the extrinsic pathway. Factor 1 deficiency may also be detected. These patients, when you do the prothrombin time or the INR, as I'll mention later, are usually the outpatients. The PT is used to monitor Coumadin therapy. So the factors that are inhibited by Coumadin therapy, these are the factors you need to memorize. For Coumadin therapy, it's 2, 7, 9, and 10. Those are the same ones that are the vitamin K dependent factors. So Coumadin, vitamin K dependent factors are 2, 7, 9, and 10. So for the prothrombin time, they're outpatients, and it measures the extrinsic factor. The extrinsic factor, there's only one factor, and it's factor 7. So I'll create a bundle for you guys later on after I'll go over these terms. But for prothrombin time, know that it's factor 7, extrinsic factor, Coumadin therapy, and outpatients. Those are the four things I want you to know. And then for Coumadin therapy, of course, 2, 7, 9, and 10, vitamin K dependent factors. You'll be asked this, 2, 7, 9, and 10. Okay. So factor 7, extrinsic, outpatients, and Coumadin therapy. Okay. Causes for prolonged prothrombin time. If your PT is elevated, meaning that you have a high time it takes a long time for the clot to form, it's probably due to vitamin K deficiency, liver disease. Those two go hand in hand because vitamin K is formed in the liver. So if you have a liver problem, you won't have vitamin K. So there goes your 2, 7, 9, and 10. And also Coumadin therapy. Okay, so Coumadin therapy as opposed to heparin therapy. The principle of the prothrombin time test is calcium. Calcium in whole blood is bound by sodium citrate, thus preventing the coagulation. As you know, if you've drawn Coag, it's the blue top tube, so that's sodium citrate. So most of the tubes that you get whole blood and you don't get a clot, what you're doing is you're maintaining the coagulation factors, and by doing that, it's by taking away calcium. If you take one component away from the coagulation cascade, and that's calcium, then you're not going to form a clot. And I'll show that to you later when I show you the cascade. Tissue thromboplastin, again with the prothrombin test, tissue thromboplastin to which calcium has been added is mixed with the patient's plasma, and that's the actual test. You have a reagent, tissue thromboplastin, in which calcium is added to. So you're replacing calcium. Now, with the calcium that you took out from the coagulation tube, you're now restoring it, replacing it with a reagent. So what you're doing is you're replacing the calcium that was taken out. Now you're mixing it with the patient's plasma, which was lacking in calcium. So once you add the reagent, you will now have the components to complete the coagulation cascade. So now you can measure the clotting time. Okay, so you take out the calcium so that you won't form the clot. You replace the calcium with a reagent, tissue thromboplastin, which has calcium. As soon as you add the tissue thromboplastin calcium down below to the plasma, then you start a timer, and then you measure clot formation. That's the prothrombin time test. INR is related to prothrombin time. INR is the international normalized ratio, and it's a way to standardize prothrombin time for patients because there are many patients going from lab to lab to lab to lab and region, that there are different ways and methods which the prothrombin time is measured. So what the INR does, it standardizes the prothrombin time, and the equation is INR is equal to the patient's prothrombin time divided by the mean normal prothrombin time to the ISI power. You're not going to need to know that formula, but what actually standardizes the INR is this ISI, because in every laboratory, the reagent that you use, like the tissue thromboplastin plasma, that has a specific ISI, and that's what actually standardizes. It normalizes the prothrombin time, and then you actually report out an INR. So that if you have a patient who's on Coumadin therapy from Arizona and they want a vacation in San Diego, and the doctor says, I need your prothrombin time every 2 weeks, and the patient's going to say, well, in 2 weeks, I'm going to be in San Diego. Well, you can go to any laboratory in San Diego and order an INR, and it'll be relatively similar to the one in Arizona. So the INR, it's a way to keep the doctor informed on how the patient is doing, and it allows the patient to travel. Okay, so the ISI is the International Sensitivity Index, and ideally you want this as low as possible. The closer to 0, the closer that the PT is equal to the INR. Okay, so it's the ISI on the reagent, and what's reported is the patient's INR. They don't report out prothrombin time so much anymore, because now the doctor wants to know what the INR is. So like I mentioned, under the INR system, all results are standardized, and it's great for patients who want to travel. Okay, so the INR patients on anticoagulants, it allows them to travel and obtain comparable results wherever they are. Okay, so it's a way to standardize the prothrombin time. INR is also useful in after major procedures like hip replacement or total knee replacement. So the doctors have target values for INR. So moderate intensity therapy like hip replacement, knee replacement, or hip fracture surgery, they're looking for a target of 2.0 to 3.0. High intensity therapy, they're looking at 2.5 to 3.5, and that's mitral valve, which is in the heart, mechanical aortic or mitral valve with risk for thromboembolism. And then for 3.0 to 4.0, very high intensity therapy, and that's mechanical aortic mitral valve and systemic embolism, despite therapeutic, INR 2.5 to 3.5. So those are the different target ranges: 2.0, 2.5 to 3.5, and 3.0 to 4.0. The next test is activated partial thromboplastin time, and it measures the coagulation factors present in the intrinsic system. So the PT, or the prothrombin time, measures coagulation factors in the extrinsic system. So fortunately, the extrinsic system, there's only one factor, and that's factor 7. In the intrinsic system, there are more factors. So the PT measures Coumadin therapy, the PTT, the APTT measures heparin therapy. And these patients are usually inpatients. You don't take heparin home and do a heparin drip while you're at home or sleeping or whatever. Heparin is given on an inpatient basis. Okay. So the principle of the APTT is similar. You take out the calcium by the sodium citrate to prevent coagulation. So the missing test, the reason why they use calcium is because it's a reagent that's easily replaced. Okay, you can link calcium to any kind of reagent. So plasma containing the intrinsic factors except calcium and platelets. That's what you have now when you in your plasma, because the calcium is removed. So calcium plus phospholipid substrate for platelets, plus an activator, plus the patient plasma. So in here, your reagent is replacing the calcium that was lost to a different reagent. It's the phospholipid substitute for platelets plus an activator. That's your reagent now. And then you add that to the patient plasma. So once you add that, you're replacing the calcium. Now you measure, as soon as you add that reagent, you measure the time it takes to clot the sample. Okay, that's the APTT. Different reagents, but same principle. Remove calcium, replace it, and start your timer. Okay. Next test is fibrinogen. Fibrinogen deficiency is pretty rare. When it occurs, it can cause severe hemorrhage. Okay, lack of fibrinogen is caused two ways: congenital, afibrinogenemia, and liver disease. If you have liver disease, a lot of patients who have real severe hepatitis, they have to get fresh frozen plasma transfusion, because fresh frozen plasma contains fibrinogen. They've lost a lot of fibrinogen. Elevated fibrinogen, on the other hand, is found in pregnancy, near term or after delivery. So the principle of the fibrinogen test is similar. Calcium in whole blood is bound to sodium citrate. You take out the calcium, and then you have thrombin plus patient plasma, and then the same thing. You just measure the time it takes to clot. A lot of places, the test for fibrinogen is actually in chemistry. So it can either be in chemistry or in hematology. There's some chemistry analyzers that will actually measure the amount of fibrinogen, because it's a protein. Okay. The next test is D-dimer. D-dimer is a pretty important test. The D-dimer is a fibrin degradation product, and it helps diagnose thrombosis. Thrombosis means the formation of a clot. And that's important because the formation of clot can kill you. It can cause severe problems, significant problems like a stroke or heart attack. Okay. So thrombosis is the formation of a blood clot inside a blood vessel. That's the definition of thrombosis. Fibrin degradation product. It's a small protein fragment present in the blood after blood clot is degraded by fibrinolysis. Okay, I'll talk about fibrinolysis later. So fibrin degradation product is a small fragment that's created from D-dimer. And I'll show that to you later when I show you the fibrinolysis pathway. There's pathways I want you to memorize. It's the coagulation pathway, the fibrinolytic pathway, and those are the two major ones. And then there's the table of coagulopathies. So in D-dimer, when a blood vessel is injured, say for example, you cut yourself, what happens is the body uses platelets and fibrin to form a blood clot to prevent blood loss. That's your first reaction. When you cut yourself, your body's going to react. Okay, so platelets become activated, and they will be mobilized to the area of injury, to the site of injury. Okay, but in D-dimer, what happens is, if you don't have an injury, and if you have blood clots forming spontaneously, the clot is free and begins to travel around the body. You don't want that. You don't want clots to be forming spontaneously, and that's called an embolus. If you have blood clots forming spontaneously, just like, like right now, listening to lectures, and all of a sudden your blood decides to clot, that's bad. So that means you're going into DIC. It's critical value situation, and you need to address it immediately, because the chances of survival untreated is very low. Okay, it can kill you, like I said. So when a thrombus is significantly large enough, that means a spontaneous formation of a clot. You can get hypoxia that can occur, lactic acid accumulation in tissues, and may result in death. Okay, this is again DIC, the spontaneous formation of clot, and it's measured by the test D-dimer. Okay, so the D-dimer test is used when there's suspicion of DVT, which is deep vein thrombosis, pulmonary embolism, and disseminated intravascular coagulation. That's the formation of clots spontaneously in your blood vessels. But DVTs, D-dimer is used as a good screen for DVT because when you have deep vein thrombosis, you're forming a clot in your veins, like the varicose veins. Well, the clot can break off in that varicose vein. And if that clot breaks off, and this is what the D-dimer test is measuring, if that clot breaks off and starts circulating around in your blood, it can end up in your lung causing a pulmonary embolism, or it can end up in your brain and cause you to have a stroke. Okay, so the detection of clots in deep vein thrombosis is very, very important, and I'll explain that to you more in the fibrinolysis lecture. DIC, I mentioned to you before, DIC can happen spontaneously, especially in leukemia. Remember the acute promyelocytic leukemia? The granules of acute promyelocytic leukemia can spontaneously cause you to go into DIC. Okay, so if you're diagnosed with M3 acute leukemia, then you might want to do a coagulation test or a D-dimer test to monitor your Coag. Okay. Deep vein thrombosis, DVT, is a formation of blood clot within a deep vein. Usually it's in the leg, predominantly in the legs. And the symptoms of a DVT include swelling of the legs, redness, pain, warmness, and gorged veins. Those are the varicose veins. Risk factors for having DAT is old age. Usually elderly people get it. Surgery, after surgery, there's risk of deep vein thrombosis. That's why they give you those compression socks. People after surgery get the compression socks. Immobilization and sitting on long flights. I actually knew somebody who was traveling, and the patient was this person was a diabetic, and they flew to India, and she was diabetic, and all she did was sit in her seat. Well, what happened was she ended up having deep vein thrombosis, and she came back from her trip with her legs amputated. Oral contraceptives can be a risk factor for deep vein thrombosis and pregnancy. Okay, so it's a very serious condition, deep vein thrombosis. That's why the D-dimer test is a very important test. PE, or pulmonary embolism, is blockage of the main artery in the lung, okay, by a substance that has traveled from elsewhere in the body through the bloodstream. So a clot has broken off a piece. That piece is now floating around in your blood, and if it ends up in the lung and it causes a blockage and that causes problems, you can have pulmonary embolism. So PE, pulmonary embolism, is the most commonly result from DVT, pulmonary embolism. DIC is characterized by the widespread systemic activation of the clotting cascade. That's why it's spontaneous. It's a spontaneous creation of clots in your blood. It's a very serious condition. Okay, and it leads to compromise of the tissue blood flow. I mentioned that, the lactic acid, etc., the hypoxia, and it can lead, and if you have that, it can lead to multiple organ damage if it's not picked up and treated right away. Okay, so here you have the formation of clots. Okay, so the formation of clots is important. We all know that the formation of clots is important, especially if you cut yourself and you don't want to be bleeding to death or bleeding all over the place. So the opposite of that is the fibrinolysis. So you have this clot forming. To stop the clot formation, you have to balance it with the fibrinolytic system. That's what's called hemostasis. So you form clots and you dissolve clots. When you have DIC, you want to dissolve clots. When you have a cut, you want to form a clot, but you don't want to form the clot forever. So you have to have the fibrinolysis to stop it, to counter it, okay? So it's a balance. The balance between clot formation and the clot degradation is called hemostasis. In DIC, as clotting factors are consumed, when I say clotting factors are consumed, that means the formation of a clot. The normal clot is disrupted and severe bleeding can occur. So at the onset of DIC, it can be sudden, such as amniotic fluid embolism. So that's why patients who, the pregnant women in labor and delivery, DIC is a threat. DIC can also be insidious and chronic, such as in malignancy. So the causes of DIC, like I mentioned earlier, tumors or acute promyelocytic leukemia. Remember, I talked about the granules of the promyelocytes can set off DIC. That's why if you're diagnosed with M3 acute leukemia, you might run a Coag panel to prevent DIC. That actually was a question that was asked of one of the MLT students that graduated from the program. She was at Grossmont, and acute promyelocytic leukemia was the patient's diagnosis, and a pathologist who happened to be walking by asked the student who was rotating on the bench. He said, what else should I order? And she correctly said, we should order coagulation panel to include a D-dimer to look for DIC. Okay, so acute promyelocytic leukemia, look for DIC. Other causes of or causes of DIC are obstetric complications like placental abruptia, preeclampsia, and eclampsia. Also, massive trauma burns, hypothermia, rhabdomyolysis, and extensive surgery. And rhabdomyolysis is the breakdown of muscle tissue that leads to release of muscle fiber contents into the blood. You can get rhabdomyolysis from electroshock, electrocution, for example. Okay, it's the breakdown of muscle tissue. It's dead muscle tissue, actually. Okay, like the dead muscle tissue you'll get from a burns, for example. Other causes of DIC: sepsis, bacterial infection. Sepsis is a positive blood culture when you have bacteria in your blood. If you have septicemia, same thing. It's septicemia, positive blood culture. You have blood culture, bacteria in your blood that can set off DIC, severe bacterial infection. Transfusion reaction. Okay, transfusion reaction. That means you've given incompatible blood, and you're actually reacting to it. When you get an antigen antibody reaction, that complex antigen antibody reaction can be floating around in your blood, can also set off DIC. Severe allergic or toxic reactions, snake or viper venom, and aortic aneurysms can also cause, those are things that can also cause DIC. Well, if you have an aortic aneurysm, you have other problems to address besides the DIC, because you're basically with an aortic aneurysm, your aorta has probably exploded and you're giving massive blood transfusions, but you'll learn that in the blood bank. So the treatment for coagulopathies or like DIC, for example, is blood transfusion. Platelets to replace the platelets, or FFP, or fresh frozen plasma for severe bleeding and acute DIC. The FFP has a high content of fibrinogen, and that's what you want to replace. Platelets, obviously, you want to replace platelets. Cryoprecipitate is another blood product, and that can be considered for those with a low fibrinogen level. You can get fibrinogen from FFP, but you can get a more concentrated amount of fibrinogen by giving cryoprecipitate. Same principle, FFP and cryo. Cryo is just a little bit more concentrated fibrinogen. And you'll learn how to make those products in blood bank. Prognosis depends on the extent of the thrombosis or the clotting. Regardless of the cause, prognosis is grim for DIC. Okay, between 10 and 50% will die. DIC with sepsis or septicemia, now you have spontaneous clotting, systemic, and it has a significant high rate of death. So patients who are in septicemia, it's not a good sign. Plasmin, okay, I talked about the fibrinolytic system. The fibrinolytic system is activated by plasminogen going to plasmin. Plasmin is the main enzyme. So I talked about clot formation and clot destruction. The balance between clot formation and clot degradation is hemostasis. Okay, remember that. But for fibrinolysis, the enzyme that is mainly responsible for the clot degradation or the clot lysis is plasmin. Plasmin is an enzyme, the main enzyme in fibrinolysis. So what happens is plasmin will cleave the fibrin gel, and I'll go into the cascade, and I'll go into the cascade not this week, obviously, probably next week or the week after. High molecular weight polymers are digested by plasmin. So plasmin is chop, chop, chop. You got clots. Plasmin will be responsible for chopping up these fibrin clots. Okay, so resulting in fibrin degradation products. The D-dimers are not normally present in the human blood plasma, but they're present in thrombosis or DIC. So you have to have thrombosis or DIC. The presence of the fibrin or the presence of DIC will stimulate the formation of D-dimers. Okay, so D-dimers are not normally floating around in your blood. It's a reaction to the presence of thrombosis or DIC. The other two tests, like for example, the plasma protein pericoagulation test will detect excess soluble fibrin. And like I said, it's less common, but it's a test that doctors still want to order. I saw some doctors ordering the test. I don't know why, but it can be helpful in clinical circumstances where there may be other disorders that can contribute to elevations in D-dimer. The main one for D-dimer is, don't forget, it's the DVT. Okay, but there are other disorders that you might want to use D-dimer to detect. And also too, the thrombin time is the other test. Thrombin time is a little bit more common than the pericoagulation test, and it involves the addition of bovine or human thrombin to platelet poor plasma. And thrombin reflects the conversion of fibrinogen to fibrin. When we go over the cascade, this will all tie in. So, you know, I talked about prothrombin and thrombin and fibrinogen and fibrin and plasmin and plasminogen. All of this will tie in when you know in detail the coagulation cascade and the fibrinolytic system. Okay, so the thrombin time is sensitive to the presence of inhibitors. Inhibitors are important to know especially if they're there, because one way to determine if you have a factor deficiency, and that's like a congenital disorder. If you're missing like factor 7, for example, you run a test, you suspect that factor 7 is missing, you run a prothrombin time, and then you run it again by adding known factor 7. And if the time corrects, then you can tell it's a factor 7 deficiency. If you're suspecting factor 7 deficiency on another sample and you add factor 7 and it does not correct, when I say correction, say for example, the normal prothrombin time will be around 12 to 14. If you run a pro time, okay, if you run a pro time and you get times in the 20s, that means there's something going on. You suspect a factor deficiency. That's a prolonged time if it's in the 20s. Okay, so if you think it's a factor 7 deficiency and you add known factor 7 to your plasma and retest it, and it comes down to normal, then you can suspect, or within reason, that it was a factor 7 deficiency. If it doesn't correct, then you probably have an inhibitor. I'm going to go over the mixing studies and rule in, rule out inhibitors, but that's what happens. I'm just introducing the concept of inhibitors that may be present, but I'm going to be going over mixing studies and inhibitors in another lecture. But I just want to introduce that concept to you today. Other methods, I did use the tilt tube method. It's a very primitive test. I worked in the laboratory that didn't have any instruments. It's a manual method where, so you add the reagent and you time the formation of a clot. Well, normally you have a machine doing that. Well, the manual method is you add the reagent. Instead of having the machine count it, you check the tube periodically and you actually visually look for the formation of a clot with a stopwatch. That's a tilt tube method. The fibrometer is a machine. It's a mechanical detection of a fibrin clot. It's an instrument that detects the formation of a clot by mechanical detection. It's these two wires that vibrate back and forth, back and forth, and back and forth. And once there's a clot formation, what it does, it completes a circuit. Once the circuit's completed, then the vibration will stop. And then at the same time, when you add the reagent, a timer goes, and once the vibration stops because a clot is formed, then that's your prothrombin or coagulation time. And then nowadays you have the automated, semi-automated methods where they measure optical density, detection of formation of a clot by measuring optical density. If the optical density changes because of the presence of the clot, then as soon as it gets to a certain optical density, then the timer will stop. Okay, so it starts when the reagent is added and it stops when it reaches a certain optical density. Okay, and finally, causes for abnormal coagulation tests. When I say abnormal coagulation tests, I'm talking about prolonged times. So if you have low levels of clotting factors, like the example I said, if you don't have low level factor 7, for example, then it can cause you to have a prolonged clotting time. Change in the activity of the clotting factor, physical activity of the factor itself, the absence of any clotting factors. If you're missing or congenitally missing a factor, like for example, von Willebrand's or hemophilia, those patients are actually missing factors, then that will cause you to have a prolonged clotting time. Inhibitors, if you have inhibitors and you have all your factors intact, but inhibitors will cause you to have prolonged times, and an increase in the use of the clotting factors. Okay, like if you increase in the use of clotting factors, that can also cause you to have abnormal coagulation times. Okay, so that is the first lecture. So now I'm going to transition now into the next lecture. Are there any questions on that, on this? I know coagulation is different than hematology, but it's a whole new part of hematology that it goes together with hematology. So and it's different, you know, no anemias, no leukemias, no RBC morphologies or anything like that. But the coagulation is part of hematology. And any laboratory that you work in, coagulation is also a part of it. So now I'm going to go over the coagulation terms, and I'm going to talk about hemostasis. Remember, hemostasis is the balance between coagulation and the fibrinolytic system. Okay, you know what thrombocytes are? They're platelets. Thrombosis is the formation of a clot. Make sure you know these terms. And you know this term from hematology, thrombocytopenia. Penia means decreased, and thrombocytes are platelets. So decreased platelet count. Thrombocytosis is the exact opposite. Thrombocytosis means increased platelet count, or thrombocythemia is they both mean increased platelet count. Okay. Hemostasis is the delicate balance between the elements controlling bleeding, i.e. the formation of clot, and those that control clotting. We don't want clotting to get out of hand, so we have to have the fibrinolytic system, because if the clotting gets out of hand, you need to put a check on it by at some optimal point, that you need to stop the clotting process by having the fibrinolytic system kick in. So you got clotting and clot cleavage. You know, the cleavage of the clots, that has to be in delicate balance. So hemostasis is a process that maintains blood in a fluid state. It keeps blood within the vessels during injury, and it localizes reactions to the site of injury. These are the three main purposes of hemostasis. So hemostasis is very, very important. That's actually the crux of this lecture. It's the balance, knowing the balance between the coagulation cascade and the fibrinolytic system. Make sure you know this page right here. 4 systems that maintain hemostasis, okay, because you'll be asked this. The vascular system, which is all your blood vessels, the platelets, okay, the coagulation system, the clotting system, and the fibrinolytic system dissolve the clot system, okay? And the vascular system components are your arteries, veins, and capillaries. So make sure you know these 2 systems. All right, make sure you know this page. The vascular system acts to prevent bleeding by contraction of the vessel, diversion of blood flow around the damaged vasculature, initiation of contact activation platelets. That's actually the start of the healing process to an injury, and the clot activation of the coagulation system. That's actually the formation of fibrin. So that with the platelets goes hand in hand in injury repair. Okay. So you have injury. What happens? You cut yourself. What happens is the platelets will start reacting to the injury. Say you cut your finger or you cut your arm. When a protein in the vessel wall becomes exposed and starts to circulate in the blood. So there's a protein that starts to circulate in your blood, and that's telling your platelets, okay, the platelets need to be activated. And that's called platelet activating factor, because the platelets will start to change. And one of those changes is that they'll become sticky. And once they become sticky, one characteristic about platelets, especially in the blood bank, you have to have your unit constantly agitating, because the platelets will have a tendency to become sticky and stick to each other. Platelets are the one, if you know anything about the blood bank, the red blood cells units will stay in the drawer, and FFP will stay in the freezer. But they don't need agitation. The one unit that needs constant agitation are your platelet units, because they have a tendency to aggregate. Okay, they have to be put on a rotator or an agitator. So in this injury that you have, is that the first thing that'll happen is platelets will become mobilized, and they arrive at the site of injury, and it forms a platelet plug. Okay, but it doesn't stop there. The platelet plug alone is unstable. Okay, and if it's just there, it'll end up disintegrating, and blood loss will continue. So what's needed is to have fibrin. So in addition to the platelet plug, you have to have fibrin to form a network, a meshwork on top of the platelet plug, and that's what forms your clot. Okay. So the fibrin mesh is called a clot. The fibrin mesh on top of the platelet plug is called a clot, and it holds the platelets together. So it's a two-step process. The platelets arrive at your injury. They aggregate together to stop the bleeding to form a platelet plug, and the fibrin is necessary to form the meshwork. Okay, so where does the fibrin come from? Well, you have the coagulation cascade, right? What I've been talking about all along. Well, the end product of the coagulation cascade is the fibrin clot, is fibrin. Fibrin is the end product of the coagulation cascade. Make sure you know what the end products of all these cascades and pathways are. Like, for example, complement, for example. Complement's pretty complicated system of proteins. And make sure that the end product of the complement cascade is cell lysis. Okay, make sure you know the end product. So the coagulation cascade, you end up with fibrin. Okay, so the fibrin plus the platelet plug is called a clot. So the fibrinolytic system, so you form clots, you're healed, but you don't want to form clots forever, right? So the fibrinolytic system reestablishes blood flow. Okay, you're healed now. Blood flow is now reestablished in the blood vessels occluded by a thrombus, and it facilitates healing. Okay, so fibrinolysis is a physiological process of removing unwanted fibrin deposits. So now your body's saying, well, I need to stop clotting. So all this unwanted fibrin that's forming needs to be taken care of, and fibrinolysis will take care of it. So what happens, the enzyme, like I mentioned in the last lecture, the main enzyme that'll cleave the clots is plasmin. So it's the clot, fibrin clot cleavage is done by plasmin. It's actually the first protein is plasminogen. Plasminogen, in order to activate the fibrinolysis pathway, plasminogen will have to be converted into plasmin. Once that happens, now you have the enzyme to cleave the clots. So the coagulation cascade, going back to clot formation, is a series of reactions that take place among circulating proteins known as coagulation factors. And the factors are usually referred to in Roman numerals, but like I said, we're not in Rome, so this whole cascade is what you'll be memorizing. In fact, it may be on your last test, is to write the coagulation cascade. It's missing some components, like where's calcium and where's prekallikrein and kallikrein and high molecular weight kallikrein. I can add those on later. But this is the basic framework of the coagulation cascade that I want you guys to know. So in the laboratory, unfortunately, since I'm not teaching the laboratory, I'd have everybody, the whole class, write this on the board after I teach it to them. So what I would do is I would write it, and then I'd write it again, and then I would ask a volunteer. But fortunately for you guys, I'm not in the laboratory for me to do that. So, but you will know it. You will know it, and I'll go over it piecemeal and teach you how to do the coagulation cascade. Okay, so this cascade, each reaction is dependent on the one prior to it. So the factors that are in circulation in your blood are in an inactive form. Okay, so you have factors, fibrinogen, prothrombin, thrombin, etc. Those are factors in your blood. Okay, but when it's in need and the coagulation cascade is activated, those factors now are denoted with an A, like 12 goes to 12A, 11 goes to 11A, factor 5 goes to 5A, etc. The activated form is denoted with an A. Okay, calcium, as I went through the test, is an important role in the clotting of the reactions. If you take calcium away, you're not going to form a clot. That's why you get whole blood in those tubes, the EDTA, the sodium citrate, the lithium, all of those. They take away calcium. And for coagulation, the sodium citrate, you're replacing calcium. And that's when you run the test, and then you time how you measure how long it takes to form a clot. But what's missing, the key thing about these tubes, is that calcium is missing. So calcium plays a key role in clotting. Without calcium, then you won't get any clots, and that's why you have whole blood. Okay, so the removal of calcium from the patient's plasma is the basis for it's the basis of the anticoagulant used for coagulation testing. Two separate pathways that can be followed: the intrinsic pathway and the extrinsic pathway. The intrinsic pathway are 12, 11, 9, and 8. 12, 11, 9, and 8. Make sure you know those, okay? You'll be asked that. Easily, the extrinsic factors, there's only one factor involved, and that's factor 7. Extrinsic pathway, remember. Extrinsic, 7, outpatient, and Coumadin, okay? The two pathways meet at what is referred to as the common pathway. So you got the intrinsic pathway and the intrinsic pathway. They meet at what's called the common pathway. And the common pathway factors are 10, 5, 1, and 2, fibrin and prothrombin time. So again, I mean, I'm giving you these factors. I'm giving you these components, parts of the pathway. It's going to be easy once I teach you the complete coagulation pathway. But right now, just know the components of the common pathway are 10, 5, 2, and 1. Okay. So at the end of the common pathway, that's actually at the end, the bottom part, the end product is the final formation of a clot. Okay, so you have the intrinsic and extrinsic pathways activated by different substances. The intrinsic pathway is activated by platelet factor, make sure you know that. And the extrinsic pathway is activated by tissue factor. Okay, make sure you know that. This is the fibrinolytic system. So plasminogen is plasminogen unless you have clot formation. If you have clots that form, that's plasminogen will convert over to plasma, because if you had clot formation, you're going to need plasma to counter that clot formation, and it's not going to work until you have excess clot present, fibrin present. So plasminogen will act on fibrinogen and will degrade that to form fibrin degradation products. So plasminogen will chop up fibrinogen, and it'll also chop up the insoluble fibrin clot. So fibrinogen naturally will go from fibrinogen to soluble fibrin, finally to insoluble fibrin clot. This is at the end of the common pathway. Remember, the end product of coagulation cascade is the formation of the fibrin clot. Well, this fibrin clot here will be detected by plasmin, and because we don't want excess fibrin to be created, and it'll create with plasminogen acting on fibrin clot, then you will form fibrin split products. So here on fibrinogen, you create fibrin degradation products. And here on the insoluble fibrin clot, you're forming fibrin split products. And I'm going to go over this in more detail in the fibrinolysis lecture. Fibrinolysis, like I mentioned, is mediated by plasmin. It's a precursor to, the precursor is plasminogen. Remember, plasminogen is the precursor to plasmin. Fibrinolysis is the body's way of keeping coagulation from becoming excessive and occluding the blood vessels. We don't want the fibrin clots to occlude the blood vessels. So in summary of the pathways, the intrinsic pathway is 12, 11, 9, and 8, okay? And it's activated by platelet factor. And extrinsic factor is, there's only one factor, and it's factor 7, and it's activated by tissue factor. And the common pathway contains factors 10, 5, 1, and 2. And it's activated by the intrinsic and extrinsic factors. So the common pathway is where the intrinsic and extrinsic factors meet. Substances that work against the various elements of hemostasis are the inhibitors. Okay, so you have all your factors intact, but if you still have prolonged times of prolonged protime or prolonged PTT, and you know you don't have any factor deficiencies, the presence of inhibitors will cause you to have prolonged times. And inhibitors serve as a control mechanism to regulate clotting and fibrinolysis. So inhibitors can be useful. In the fibrinolytic pathway, you have plasmin inhibitor, slows down the action of plasmin because you don't want plasmin to get out of control too. So you're going to need to have plasmin put in check, and plasmin inhibitor will do that. And again, this will be discussed more in the fibrinolysis lecture. Protein C and protein S, that's another separate lecture. Those two are inhibitors of factors 5 and 8. And a large number of pathologic inhibitors and drugs can disrupt the balance of hemostasis. Okay. First factor is factor 1, fibrinogen. The main substrate of the coagulation system. Fibrinogen, the term itself looks like a precursor, and fibrinogen will form fibrin. Okay, fibrinogen forms fibrin from fibrinogen, and fibrin is the final product. So fibrinogen will form fibrin. Second one is factor 2, prothrombin. Prothrombin looks like a precursor term, and prothrombin will go to thrombin. Okay, it's made in the liver, serine protease precursor, and it converts to thrombin. So prothrombin, the precursor, will go to thrombin. And thrombin will split fibrinogen, stimulates platelet aggregation, and activates cofactors protein and C. So the placement of these factors, the prothrombin and the thrombin, again, will be clear when we go over when you memorize the coagulation cascade. Factor 3 is thromboplastin. It's the plasma protein that catalyzes the conversion of prothrombin to thrombin. Okay, so that conversion, prothrombin to thrombin, needs to be catalyzed by thromboplastin. And thromboplastin is found in the brain, lung, and other tissues. If you recall, the Prothrombotime, the reagent is thromboplastin. They get the thromboplastin from, they actually make it from brain tissue and lung tissue. Okay, thromboplastin is also found in platelets, and I'll discuss that in the platelet lecture. And another name for thromboplastin is thrombokinase. 4 is calcium. We all know, I talked about the importance of calcium in the coagulation cascade. You take it out, you won't form a clot, right? You get whole blood. So it's required in several steps. That's why it's a good reagent to take out, because you remove calcium, you definitely will not form a clot. And calcium works with 11A, 9A, and 10A. Calcium is factor 4. Factor 5 is, another name is labile factor. So make sure you know the alternate names, proaccelerant or labile factor. It functions as a cofactor. It's not enzymatically active. A precursor that speeds the formation of prothrombin to thrombin. So 5 is important for the conversion of prothrombin to thrombin. Factor 6, forget about factor 6 because it doesn't exist. Okay, there's no such thing as factor 6. Factor 7 Factor 7 is, remember, is the extrinsic system, also known as proconvertin. Make sure you know the alternate name. It works in conjunction with tissue factor, and it activates factor 10, okay, on the intrinsic pathway. And it's also made in the liver. Most of these factors are made in the liver. Factor 8 is anti-hemophilic factor. Factor A, okay, factor 8 is also known as anti-hemophilic factor A. And this actually circulates in the blood as a complex because it's bound to what's called von Willebrand's factor. Okay, I'm going to be talking about that in the coagulopathies lecture. So when an injury occurs, the complex of factor 8 plus von Willebrand factor will separate. Von Willebrand factor 8 will separate from the von Willebrand factor. Factor 9 is anti-hemophilic factor, also known as Christmas factor, not because of the season, but there's an individual, this boy named Stephen Christmas, and he was found lacking in factor 9, and that's a certain type of hemophilia. Okay, factor 9 hemophilia. Factor 10 is called Stewart-Power factor, converts prothrombin to thrombin. It's also made in the liver. Factor 11 is plasma thromboplasma antecedent. This activates factor 11. I'm sorry, factor 9, and it's the beginning of the intrinsic pathway. Pathway. Factor 12 is Hageman factor. It is activated by collagen, and it activates factor 11 and prekallikrein. So this is early on in the intrinsic system. Factor 13 is an important factor, especially, for example, women who just delivered and their umbilicus is in the healing process. So what happens is after delivery, the umbilicus will be detached and the healing process takes place. If it doesn't heal properly and it continues to weep, then that means you have, it's a good indication that you have a factor 13 deficiency. So I'm going to go over the factor 13 deficiency, but that's also called fibrin stabilizing factor. If you don't have that, then your fibrin clot in the healing process will not heal properly. Okay, factor 13 is an important one. Prekallikrein is also known as Fletcher factor, and it converts to kallikrein. So prekallikrein is the precursor, and it'll convert to prekallikrein. Early in the intrinsic pathway, factor 12 will cleave prekallikrein to kallikrein. And here's another way of looking at the coagulation pathway. This is the one you're not going to know, but I just want to know that there's another version. This is the extrinsic pathway, starting with 7, going down to the common pathway. This is the common pathway down here. And here's your extrinsic pathway, 7 going to 10 and 10A. Okay. And then you have the intrinsic pathway, starting with 12, 11, 9, and 10. Just remember those numbers, 12, 11, 9, and 10. So when I teach this to you, those are the 4 numbers that you'll need to know. The intrinsic pathway also going down to the common pathway, and that will be the intrinsic going to the common pathway. And that's it. A lot of information, a lot of information. Are there any questions? You're going to see this again because I'm going to reiterate and emphasize the reactions, like 12 going to 12A, see the activated forms, 12 going to 12A, 11 going to 11A, 9 going to 9A, and this factor 8 and factor 5. And I'm going to teach all of this to you. Okay. Are there any questions? Okay. If not, okay, the way we're going to do this is that I'm going to email each of you your quizzes and your exams. Okay, so there's 4. You're going to get the quiz on lecture 18. You're going to get the exam 4 multiple choice, exam 4 matching, and then you're going to be doing the mega matching. I hope everybody studied that. So and you probably learned a lot from that mega matching studying. Okay, so what I'm gonna do is I'm gonna email it to you, and I'm gonna email it to you, and as soon as you finish, because I'm gonna be proctoring you, like I'm gonna be looking at all of you. As soon as you finish, email me back your quizzes, and then as soon as I get your email back, then I'll dismiss you. Okay. 7, 8, 9. Okay. All right. All right. So. So as soon as you get this, then you can go ahead and start.
Professor Badgett.
Yes. Yes, Rudy.
I need to step away from my computer real quick. I have somebody doing some repair work on plumbing here, and I need to move my car out of the way so they can leave my house here.
Okay.
Thank
All
you.
right. All right. You have my permission. Okay, I'm sending out your quizzes and exams right now. So good luck, and hope everything goes well.
Thank you very much.
Oh, you're welcome, Rudy. That'll cost you 20 points. No, just joking.